Hi class, welcome to the online session. We are with the third part for gastrointestinal pathology. We have 4 slides for today, starting with slide 111, that is chronic diverticulitis. We have slide 105 with Crohn's disease, slide 109 with ulcerative colitis, and our last slide will be slide 106, that is ischemic bowel disease or infarction of the bowel. Okay, so let's start. Okay, is that clear? Okay, so our first slide would be slide 111. This is labeled as chronic diverticulitis. We would commonly encounter this one among our elderly patients. And chronic diverticulitis would refer to the presence of inflammation of a diverticulum. A diverticulum would refer to an outpouching that is observed when we open up the mucosal surface. We would see some small openings ranging from 0.5 to 1 cm in diameter. And these openings would be similar to that of the Meckel's diverticulum or that of the appendix. Okay? And this would be attributed to the attenuation of this particular layer of the wall, and this would be the muscularis propria. So as you can see, we would identify the presence of the longitudinal and circular fibers, and then in this portion there is the attenuation or absence of the portion of the muscularis layer, and this is replaced, or this would contain the mucosa and submucosa, and this is the outpouching. Okay, so you can see the downward proliferation of the mucosa and submucosa up to the muscularis propria. Okay, in some cases it can go beyond the serosa, and it would appear like a finger-like projection. If we are going to remove the fats on the serosal surface, we would be able to identify for these finger-like projections, which would be consistent with diverticulum. So this is a diverticulitis. The reason for that, for the diagnosis, is the presence of inflammatory cells, mononuclear cell infiltrates in the surrounding tissues. Okay, so you can see presence of segmenters, lymphocytes, plasma cells in the area. Okay, so you have presence of plasma cells, lymphocytes in the area. Okay. So next we have slide 105. This is Crohn's disease. Okay, Crohn's disease is an entity that would fall under the inflammatory bowel disease, or IBD. Historically, it would present with low incidence in Asia. However, currently we observe to have more cases than before. This is seen usually in the United States and Europe, but lately there's a surge in the number of cases. So we have two forms of IBDs. We have the Crohn's disease and the ulcerative colitis. There are differentiating features for them, but there can be an overlap of the features. So for Crohn's disease, one of the main features that would be highlighted would be the manner to which we would see the inflammation. Okay, so there's an ulcer. Here, this would be the mucosa muscularis and then the submucosa muscularis. There's an ulcer here, okay, replaced by granulation tissue. And then here we have inflammation of the mucosa. Here, a lot of inflammatory cells. Submucosa, and it goes into the muscularis propria. So it presents with a transmural type of inflammation. In addition to that, we would see this nodularities, these aggregates of epithelioid histiocytes. Okay, so these are epithelioid histiocytes that would form non-cacheating granulomas. So non-cacheating granulomas can be seen or would be a feature of Crohn's disease, and this would be a differentiating factor from ulcerative colitis. I see also the feature of granuloma. What's this one? Presence of multinucleated giant cells. Other features that we would be able to identify in the slide, this one. We have here the ulcer. The ulcer can extend into the submucosa or even to the muscularis. These are what we call as the knife-like ulcers, or they are also called linear fissure or linear ulcer. Okay. If we go into the mucosal glands, we can see the presence of inflammatory cells, okay, abutting the glands. This is what we call as cryptitis. C-R-Y-P-T-I-T-I-S. Cryptitis. Abscesses can be observed, but I think it's not present in this particular slide. Okay. Genetic mutations can be associated with Crohn's disease, like NOD, NOD2, although only 10% of those with NOD NOD2 would have the Crohn's disease. ATG 1611, L1 and IGRM. So those are genes, if present, can be associated with Crohn's disease. They are susceptible to. Grossly, the Crohn's disease would be associated with a cobblestone appearance. A cobblestone appearance. And it can involve the small intestine and large intestine again in only 30%. So majority of cases would be in the small intestine in 40%. The next slide is slide 109. This is ulcerative colitis. So another form of inflammatory bowel disease. Ulcerative colitis would involve the colon, the large intestine. So it can be seen in the rectum, it can be seen in the transverse, as long as it's in the colon. However, there can be instances that it would extend into the ileum. That's why it is also called backwash ileitis if the ulcerative colitis would involve the ileum. Okay? So, one of the features for ulcerative colitis would be the presence of pseudopolyps. So you can see here the enlargement. Sorry, okay, here you have a very large amount of mucosal content in this particular portion, brought about by the presence of hemorrhage and inflammatory cells in the area. Okay. And the submucosa would be this one, and then the muscularis. So pseudopolypoid formation can be present You can see the pseudopolyp here. Okay, and this is due to the intense inflammation, congestion, and edema. Okay. Another feature for ulcerative colitis, in addition to the pseudopolyp, would be the presence of inflammation of the mucosa and submucosa only. Okay, notice that there's minimal inflammation into the muscularis. So more of mucosal and submucosal inflammation in ulcerative colitis. Okay. It is also the condition wherein we would associate it with the megacolon, okay, because of the formation of pseudopolyps. And granulomas are not observed. Cryptitis can be seen. So let's try to look for a cryptitis, although I see a lot of crypt abscesses. Okay? So cryptitis, if the inflammatory cells would only be situated at the area of the lining, but if we would see the presence of cells, inflammatory cells within the lumen, then that's the time we call it as crypt abscess. So this is a crypt abscess. Okay. So this is crypt abscess. This is a cryptitis. Okay. Cryptitis, crypt abscess, they are different. Okay. So last slide is slide 106. This is ischemic bowel disease or acute infarction of the small bowel. So what is the reason why our patients would sometimes manifest with this one? Okay, so here. So ischemic bowel disease can be brought about by hypoperfusion. The moment that our patients would have myocardial infarctions or would have shock, or the use of illicit drugs that can lead to hypotension. This can lead to hypoxic injury. This would involve the celiac, the mesenteric arteries that would supply blood to the intestine. And aside from that, there would be a reperfusion injury because it's not a single circulation. It's a dual circulation consisting of different arteries. So the type of infarction that we would see would not be white infarct but red infarct, okay, because of the reperfusion. So there are certain segments in the large intestine that can be affected by this one. These are what we call as the watershed areas. And watershed areas would be associated with the termination of the vessel, of that particular vessel. Okay, so an example would be the splenic flexure, the sigmoid colon, as well as the rectum. So these are the ones that are prone to ischemic bowel disease or acute infarction. So what are the things that we would see? In this particular area, okay, you still would see the presence of the glands. In this portion, you would see the presence of mucosal infarction. Okay, wherein we have the ghost outlines of the glands. Then we see the presence of hemorrhage. This particular area, the glands are prominent. They are viable. Okay, they are viable. They are not necrotic. You see the muscularis mucosae. So this is still viable area. So the infarction would be limited to the mucosal portion. Okay. In some areas, like this one. Okay, so this is a particular area that would show the ghost outlines of the mucosa, but there's not so much identifiable viable cells. You can see the presence of the glands here, okay, but they are lined already by necrotic cells exhibiting cariolysis. When you have cariolysis, it means that there would be a decrease in the chromatin pattern or fading of the chromatin. Okay. the necrosis would extend not only from the mucosa, it goes also to the submucosa, and let's try to find out if there are areas of, I think this one. Okay. You can see some areas that would include already the muscularis. This one. This would include the muscularis portion. Okay. So those are the slides that we have for this session. So kindly read all the chapters or the pages that would pertain to those slides. Okay, so stay safe, Stay safe and good day.